Thank you very much. So to begin the course, we have Dr. Krishna Prasad, who will be beginning the story with the Collamer lens. He is the medical director of Prasad Netralay at Udupi, Mangalore, and Sulia, and he's again a member of the scientific committee. So all to you, Dr. Krishna Prasad.
Thank you, Dr. Sonu. First of all, to include me in such a wonderful instruction course. This has been, I think, Sonu's dream that this has to be in the prime time in the morning hours. He always tell me, let's hope that the coming days it will be in the main hours. So I will not be talking about what are the different types of phakic lens available in the market. I think the previous speaker might have told what and all available in the market, but just postage chamber, I think the most popular one is from the Star Surgical, that is implantable Collamer lens, and along with some of the Indian company IPCL or ICL Phakic lens available in the market. But just to tell you about, these are the FDA approved or with the CE mark, but most of them, I think, as far as I know, that it's not available in especially in the Indian market and even in the SAARC countries. The most popular one is the implantable Collamer lens. So let me come to what exactly this Collamer. It's a collagen copolymer. So basically, I just want to tell you, I think till today, I think it's a proprietary material only for Star Surgical. Of course, originally developed at the Fedorov Institute in Moscow. Then later on, it has been licensed from biomaterial collagen. So the key to success this particular product is mainly because of you have got a very long-term safety and results with the ICL. So what exactly this Collamer? It's a hybridization of both collagen and copolymer. So what exactly this Collamer, which is a hydrophilic hydroxyethyl methacrylate based copolymer material, which blends the collagen and the UV absorbing chromophore. So because of this class property, it provides biocompatibility and exceptional optical performance. Yeah, it is a hydrophilic, but with an integrated anti-reflective interface and very easy to implant if you become the best in the implantation. The one very important point I just wanted to tell you here, it transmits the light in a way which is similar to the natural crystalline lens, and because the material characteristics are nearly identical to the human crystalline lens. So this is the one important point I picked up. Collamer prevents protein deposit. This is the one testing done in laboratory to demonstrate how Collamer repels the natural occurring proteins. So a commercially available cell solution was used to simulate the cell found in the aqueous. In one different acrylic and Collamer lens was placed, cell solution for 1 minute. Then what you have done like this. So always Collamer, which is negatively charged, because of this it repels the protein, and less protein results in fewer cells and a quieter eye. See, if you see this electron biomicroscopy picture, you can see in acrylic lens after 1 minute exposure to the protein mixture, which is magnified for 1000 times, you can see how much is the protein deposition here. But compared to the Collamer, after 1 minute exposure to the same protein mixture, which is magnified 1000 times, you can see near absence of protein deposition. This you have to see. So then the other advantage with the fibronectin and the Collamer, always it attracts the fibronectin, and which develops as a monolayer on the surface of the lens. So once this monolayer is formed, after that this Collamer is not recognized as a foreign body inside the eye. This is what I just say, that the pure collagen, because of this property, there is no source of any infectious disease unless and until you introduce. No other biological product, no virus, no bacteria, no protein. So post-operatively, if you do the surgery well, the flare and cells and even inflammation will be minimized. Probably I think this is the ideal lens, especially if you are operating a diabetic patient, patient with a chronic uveitis, patient with the iritis, and even some of the inflammatory condition of the anterior chamber. So let me come to the point of YAG resistance. This is also very important. Later on, like some of us still you know that after patient undergone cataract surgery, still if there is a residual error, still you can implant Collamer lens. But if you see that once you hit the YAG laser, after exposure, suddenly after some time it comes to the original state. This is about same thing I am explaining you. If you pass this, see you can note that 2 laser marks immediately after the YAG laser procedure. Then after 15 minutes almost disappeared. After 30 minutes you can see anything. So compare with the hydrophobic acrylic lenses. So in water content, Collamer has contained around 40% water content and 95% of the water content on the lens surface, and refractive index is 1.442. So if you take the refractive index of the aqueous, which is almost like 1.336, that means the refractive index of the Collamer, which is quite close to the refractive index of the aqueous, that is the reason it acts like a inert material. So coming to the optical quality, transmittance of these lenses, if you can see when the light passes through a 300 micron central spot on the test lens, the photometric receiver detects both light transmitted and reflect on the results of internal reflections. See, if you can see, there is no aberration if you are having a comparison with any of the acrylic material. This you have to agree. So the aberrations will be much lesser or next to the zero in Collamer material. Let me come to the what is its long term effect after you implant the Collamer lens within the eye. Especially everybody should look into the how much is going to be the endothelial loss. See, if you look at the different studies here, almost the overall the endothelial loss is almost only 1.5% per year, which is very minimal. If you take out after 5 years, only 7.7% endothelial loss after the ICL implantation. So if you see after 10 years also, there is plus or minus only there is a loss of around 300 endothelial cell count, which is almost negligible. So of course, this is I think Dr. Sanjay Chaudhary is going to talk about that. But quality of vision after Visian ICL implantation is very important to know that the quality of vision always much better compared to the whatever you promise to the patient, because it is because of the property of the material which is quite equal to the property of the crystalline lens and the aqueous humor. So in the end summary, I just wanted to tell, because of this Collamer, which is a biocompatibility, so post-operatively you have to do the surgery really well. If you remove the most of the viscoelastic from the eye, you will have a quiet eye next day, and the quality of the vision is always better than the promised. If you, I think for a couple of cases or maximum 5 cases, I never had a single problem with my Collamer implantation, very easy of implantation. Of course, if you ask me, this is the best material for phakic IOL surgery. Once again, I thank Sonu for the wonderful opportunity. Thank you one and all.
Thank you. Dr. Kundi, that was a wonderful presentation. In fact, you have been a very long time user of this material. If you remember the time when the V4C model was not there.
Yeah, we both were, I think, part of ICL Symposium at least 7-8 times last 10 years.
So, at that time when the central hole was not there,
yeah,
and an ICL was in the eye, and if you did not know an ICL was in the eye, it was so transparent that many a times you would just miss it in clinical examination. It's only when the ICL started having a hole that you started knowing that yes, this eye has an ICL in the eye. That was the quality of that's the quality of material.
Except sir, like except for the price factor, I think now the other than the price factor, but if you ask, I think you should give the equal options. If someone wants to get rid of their glasses, along with the cornea refractive surgery, still we can give the same options like Collamer as a first line of treatment, sir.
What is your experience with the patient's acceptance of ICL as an option versus LASIK? Because when your number goes beyond 8 or 9, you offer a patient an ICL. Does the patient accept it comfortably, or he still says, I want to get a LASIK done?
No. It's all depend upon what you convince to the patient, and none of my patient except for this thing, nobody say that
Is there some fear that I would rather prefer an extraocular surgery versus
No,
intra?
there is absolutely
nothing.
no fears.
So Dr. Kudlu has another course in the another hall. So any questions for Dr. KP, they're most welcome. I would encourage if you have any questions to Dr. KP Kudlu. So I have one question, KP. When you are counseling these patients,
Yeah.
so do you offer the whole refractory armamentarium to all your patients, or your ICL patients would be only those LASIK reject patients or patients with diopters more than 8 or 9, where you really feel they wouldn't be fit into SMILE or LASIK? Or do you offer ICL to all your patients? I mean, my question is very straightforward. Is it just limited to the LASIK rejects, or you offer to
No,
maybe
all my patients, actually I practice in a very small tier 3 city, but every patient I tell that there are 4 different types of treatment to get rid of your glasses. I start with the PRK, next with the LASIK, next with the SMILE, then with the ICL, implantable Collamer lens. So it's up to the patient call to decide, and whatever the borderline cases are there, especially for refractive, I not even tell about the refractive procedure, straight away I convince them for ICL surgery. My numbers are less, but still we always give them the option as a first line of treatment, borderline cases.
yeah, please. Can we have a mic to him? Please hand mic.
There's one question for you. I would like to know about the central hole. Does it have any effect on the best corrected visual acuity?
No, best corrected visual acuity doesn't have any problem, but few of the patient for some days, period of 1 week to 15 days, some of the patient, when they look at the bright light, especially the light, tube lights, sometimes they see that there is halos around, but once they come for 1 month follow-up, none of the patients say that I had initially, but now I don't have. I think it is not going to be an issue at all.
It's not a factor at all.
Yeah.
Thank you.
So the basic concept of the hole was that the size of the hole is 360 microns. So in the clinical studies, the size of the hole, they varied from 200 to maybe 400, and what they came up was that 360 100 micron hole was the minimum size where, you know, it doesn't cause any dysphotoptic symptoms, as long as the lens doesn't get grossly decentered. So if you have an adequate sized vault with a properly centered ICL, it usually doesn't affect. And I second his voice that initially some patients may crib during night driving. They may complain of some glare or starburst phenomena, but these usually subside within a period of 2 to 4 weeks. What is your take on this?
In fact, I'll pick up this question. I have a presentation of how many percentage of the people do complain of halos, and what is their outcome, and how do you get them out of it. Right. So there will be some people who will just get used to it and they'll be comfortable, whereas there'll be some people who will say it still persists and you have to get them out of it. So I'll just be talking about that in my next talk.
So I have a question to Dr. Kudlu.
Okay.
Uh, question is that you have a long time experience on ICL, but what is your experience about secondary glaucoma development after putting the ICL?
See, secondary glaucoma can be because of 2 factors. One is retained visco, angle getting too narrow. Right.
Yes.
So retained visco was an issue initially, but recently we removed the visco so well that now for the last few years the visco has not been a problem for secondary glaucoma. Right. Ever since initially you used to have secondary glaucomas because your PIs were inadequate, especially when you were making YARC PIs, and sometimes they used to close or something. So now ever since you have had the central hole, we have never faced an issue of secondary glaucoma unless you have a very high vault and a very shallow AC and the iris falls on the cornea, which is a remote possibility.
If your white to white is perfect, sir, normally this part, most of us, we neglect. Whatever the machine gives, we try to calculate. But what I do normally, first even with the ARP scan, whatever it measures, I measure with the digital calipers. Then once again on the ruler I keep it, I cross check. After I check the white to white, I tell my other co-consultant to even check the white to white. Provided both readings are same, finally I send for order. If your white to white is ultimate, there is no question of next day, provided you have to remove the visco also. I always tell, I take out with the Simco and I stay within the anterior chamber after the ICL implantation for 1 minute. let the all visco come out. Next day there is no question of developing glaucoma.
So I have another question, to Dr. Kudlu, that suppose your sister needs a correction of -6.
Yes, sir.
She has facility of LASIK, of ICL. Which one you will prefer?
Definitely I'll go for -6 means I'll go for ICL.
ICL.
Yeah.
Basically, because of good, optical corrections, there's no aberrations with the ICLs, which corneal surgery might produce aberrations. So if things are all okay, like you have a good AC depth, good angle area, and patient doesn't have other things, the ICL may be a better choice. But it all depends how a surgeon takes it. There are surgeons who will prefer, simple LASIK or SMILE in these situations also.
What we have found out is on the optical biometer we get different reading of white to white than on the caliper. So which
I
is
think
better?
we'll come to that subsequently. Let me make my presentation, which is almost similar diagnostic things. Can I have my